Personal, the transition time, right? You know, I this year, and people all have different. It's happy for your kids, but it's like, oh gosh, you know, we're
Okay. I want to welcome everybody to our annual Truman Katz Grand Rounds. Our guest speaker today is Lainey Ross, who within our Bioethics Center is a longtime friend and colleague. But before I introduce Lainey, I'd like to spend a few moments honoring Truman and acknowledging him, particularly because every year there's new residents who come who don't know who Truman Katz is. So it's my privilege and honor to be able to tell you about him. Truman was the CEO of Seattle Children's from 1979 to 2005. And he really led Seattle Children's through a very critical time in its development to create the foundation for where Seattle Children's is now. And he really did a number of things related to the financial management, related to generating the broad community support that Children's has with the community, as well as developing new innovative programs. And particularly, he was responsible for developing the relationship with University of Washington School of Medicine, as well specifically the Seattle Cancer Care Alliance was a pivotal issue. And he also had the vision to anticipate the need for a robust research program that's now really central to Seattle Children's. This is, when he came here, he was, looks different. For all, I should put, this is Truman right here, for those of you who haven't seen him. Okay, yes. So he looks a little different from how he looked in 1979. But Truman has had a long-standing interest in ethics. He's been interested in the issues of quality of care, the issue of respecting the role of families. And when Truman was ready to retire, the Board of Trustees decided to endow our Bioethics Center in honor of Truman, as well as endowing this lectureship. And so it's really my honor to recognize Truman as I introduce Lainey. So let me tell you about Lainey, who is also a real privilege for me to introduce. Many of you may know Lainey if you come to our summer conference, because Lainey is tied for the record, along with Norm Faust, for the people who have presented at our conference the most number of years. Lainey is at the University of Chicago. She is a general pediatrician. She's also trained as a philosopher. She is interested in every single aspect of pediatric ethics that you can imagine, from clinical ethics to research ethics, issues related to transplant, issues related to genetics. She probably has more publications and more books than anybody I know who's a pediatrician. An ethicist, but more importantly, what she has to say is always very provocative and very interesting, and I think that we'll really enjoy what she has to say to us today about the ethical issues of newborn screening. So with that, let me turn this over to Lainey. I just press a button here, see if I can get that to work. There you go.
Thank you very much. Thank you very much for that very kind invitation. It's always a pleasure to come here, and I always bring good weather. So that must be that you invite me at the right times of the year. So today I'm going to be talking about the ethical policy evaluation of newborn screening for lysosomal storage disorders. Lots of abbreviations, as you'll see as we go through. I have no financial relationships to disclose. I currently serve on the Illinois Department of Public Health, Genetic and Metabolic Disease Advisory Committee. My term ends in October. I'm not sure who's happier. The views expressed are my own. So my goals today are to review the history of newborn screening in one slide or less, examine the expansion of newborn screening in the past decade, and then look at 3 case studies of newborn screening, specifically looking at 3 types of lysosomal storage disorders: Krabbe's, Fabry's, and Pompe's. History of newborn screening starts with Bob Guthrie. He developed both the bacterial inhibition assay as well as the filter paper on which to collect blood in order to begin PKU screening, which began in the early 1960s. And it was actually quite controversial at the time. Guthrie and parent advocacy groups really sought to make the testing universal and mandatory. It was the first time that we could actually diagnose, in a sense, a metabolic disorder like PKU. And it was also, there were some treatments that hadn't actually been fully tested, but that we thought might be able to prevent. And no one actually knew how common it was, but it was the 1960s. We had a president who was very interested in intellectual disabilities, having a sister who had intellectual disabilities. And so there was a lot of momentum for trying to move it to universal and mandatory. The physicians, on the other hand, the pediatricians, including the American Academy of Pediatrics, really objected to this. It wasn't clear that we knew who we should be identifying as affected and how to treat them or for how long. We had no idea of what we now know as maternal PKU, the problem with after treating these kids as kids and then they go off the diet, and then even if their children don't have PKU genetically, that they get exposed to such high levels of phenylalanine that the children can be born with intellectual disabilities. So there was a lot we knew that we didn't know about it, and again, the treatment actually had never actually been tested in any type of clinical trial. It was also the idea of, that the government didn't have the right to tell us how to practice medicine. So a lot of controversy within the pediatric group, but Guthrie, as he describes himself in his biography, his autobiography, that he was the child of a used car salesman and was able to sell it, and within a decade it was actually mandatory in 42 states. That was in the early 1960s. It wasn't until 1968 that we actually developed some criteria for how we should think about population screening at the population level, which is what newborn screening is. And that was with the development of the Wilson and Youngner criteria that were actually not written specifically for pediatrics, but written in 1968 for the World Health Organization by Wilson and Youngner. And as I said, not specifically designed for newborn screening, although with slight modification, it's still been considered very important for the next 4 decades. And these criteria basically speak about that we should have, am I not speaking? Sorry. That these criteria include an adequate understanding of the natural history, that we should have a recognizable asymptomatic stage, and agreed upon policy upon whom to treat. So 1960s through the 1990s, we're adding one condition every several years to decade. So it's expanding one condition at a time, in a sense, for every condition we're developing a new test. And then we developed tandem mass spectrometry, which allows us to have a platform technology to do a lot of screening with one condition, with one test. And so what this led to is those states that adopted tandem mass were able to do a lot more conditions because they could do it with one platform technology. So in the early 2000s, you have West Virginia screening for 4 conditions, Michigan screening for more than 40. So raising lots of issues of equity. And so in 2002, the Maternal and Child Health Bureau commissioned the American College of Medical Genetics and Genomics to outline a process of standardization of outcomes and guidelines for state newborn screening programs. And in 2005, the ACMG HRSA committee proposed what's called the Uniform Panel, which included 25 primary and 29 secondary conditions. There was strong support from parent advocacy groups. This is a theme you're going to hear throughout this talk. There was strong criticisms from ethicists. Their main criticism was the methodology that was used by the ACMG HRSA, which I will not get into in extreme detail here, but some of us in this room, I think Ben is on that paper with Jeff Botkin and myself as well, looking at some of the critiques of the methodology. One of the complaints, for example, was that to the extent that families, that it was voted that it was as important if the family perceived benefit as if the child got any clinical medical benefit from testing. And there was also a lot of points given to empowering or increasing the number of conditions tested for if you could use a platform technology like mass spectrometry. Interestingly, the geneticists and the laboratorians were actually on both sides of the issues. So you had the parents here, the ethicists here, and some geneticists and some laboratorians siding with each group. But today, all states screen for the conditions included in the recommended uniform panel. The uniform panel now no longer only includes the blood spot, but also includes hearing tests, pulse ox for critical congenital heart disease. There's been some small expansion of metabolic genetics since it was first adopted in 2005, including for SCID. Pompe was actually approved this year by the discretionary committee. Some states screen for additional conditions. New York screens for Krabbe disease, and that'll be one of my case studies. And Illinois, where I live, and Missouri screen for a number of other lysosomal storage disorders. Missouri is actually several years ahead of Illinois, which is still in pilot testing. So the 3 case studies that I want to do today, Krabbe, Fabry's, and Pompe disease. We'll start with Krabbe's disease. This is for those of you who come from my coast in the world. Anybody know who this is? Bill Kelly, who is the founder, he and his wife, of Hunter's Hope. Their son was diagnosed with Krabbe's disease. So Krabbe's disease is the diminished or absent activity of the lysosomal enzyme beta-galactocerebrosidase activity, or known as GALC. There are 4 phenotypes. There's an early infantile, there's a later onset, there's an adolescent, and there's an adult onset. Newborn screening involves a rapid test for assessing, followed by DNA analysis. And the biggest problem is that neither enzyme activity nor genetic mutation reliably predicts phenotype. So the Kellys were very instrumental in getting this approved in New York, and actually worked with the governor at the time. And at the time, the New York geneticists, neurologists, lots of different people got together, and although they all recommended against adding Krabbe screening, they knew that this was going to be a political decision, and they actually did an incredible job of trying to develop standardization like protocols and criteria for when they would use treatment, which it would be a stem cell transplant for the early infantile phenotype. The information that we had at the time as they were thinking about whether to implement newborn screening for Krabbe's was there was a clinical database and registry developed, funded by Hunter's Hope, by the Kellys, and they had actually started it in 1997, and by 2006 they had questionnaires from 332 parents of children with Krabbe's disease. Most of the parents who had responded, this was, totally voluntary. There were call-outs. If you have a child diagnosed with this disorder, please write us. Most represented early onset. In fact, of the people who were listed in the registry, 70% had presented before 6 months, so that would be the infantile, and another 19% presented between 7 months to 1 year, which would still be the early onset. The most common early symptoms were crying and irritability, stiffness, seizures, poor head control, poor feeding, and fisting. And as the disease progressed, these children, the crying and irritability lessens, as did the spasticity, but then become superseded by immobility, loss of vision, loss of smiling, need for NG feeds, and a pretty devastating condition. So at the time that they were implementing this in New York, it was presumed that about 90% of cases of Krabbe's disease that would be diagnosed in a newborn screening program, approximately 90% would present early, within the first year of life. So here was their methodology. I'm an ethicist, so the details in some ways are less important for me, but the point is that it's a rigorous protocol. They're trying to minimize the number of false positives, but they also need to minimize the number of false negatives. The agreement at the time was who should be treated, those with a 30 kb deletion, but otherwise they realized that they had no idea about genotype and its correlation with phenotype. The problem is that when you want to do a stem cell 3 months before symptoms develop, and there's no way of actually knowing when symptoms are going to develop. You want to do it 3 months because you want to give it time for the stem cell to transplant to take, because if once the symptoms have started and it takes several months for the whole bone marrow transplant to take, you're regressing throughout that whole period. The symptoms are getting worse. They developed again then an algorithm for staging. And this was actually developed by Escalar and group, and they were trying to figure out, again, when would be the best time to transplant these kids. You don't want to do it too early, because if you're not going to develop symptoms for 40 years, the risks and the harms of a bone marrow transplant are significant enough. So you want to do it 3 to 6 months before you're going to develop. And again, since we don't have a genotype correlation with phenotype, we really don't know when that timing is going to be. And in fact, another real problem is that with the infantile form, sometimes the symptoms have already begun in utero. So by the time the child is born, you're 3 months too late. So when they diagnose somebody on a positive newborn screen, this was the follow-up. Because remember, we have these kids, they've been, quote, diagnosed with Krabbe's, but we don't know who to treat. So this is the follow-up. So if they had a high risk, so they had a really low GALT, you're going to see that they wanted to follow these kids monthly. And then if the kids hadn't developed any symptoms, to follow them every 3 months. And with a pretty extensive follow-up that would need them to come to a major academic center. If they had moderate, it was slightly less intensive, but there were all of these exams. And I have to say that when you talk to people who are in New York, you find out that a lot of parents drop out at some point because it's just so rigorous and their kids seem fine to them. So here was the first results that get published in July of 2010. Total newborn screens were over 1 million. They had 187 positive with 185 undergoing confirmatory testing. And you can see that you follow it down, that many of them, do I have a pointer? I must. Right, so if you follow it down, you can see that they had 9 positives with enzyme activity of less than 0.5. They did neuro follow-up and neurodiagnostics, and they had an abnormal exam with the 30 kb deletion, which is known to be the infantile form of N of 4, all of whom were offered transplant. 3 of whom got transplanted, 1 died, 1 was doing poorly in 2010, and 1 was doing well. 1 refused transplant and died with about 8 months later. Of those who had a normal exam, they had 3 who continued to come in for follow-up, 2 who refused follow-up, and we have no idea whether these will be later onset Krabbe's disease. For those who, after the confirmatory testing, their results are actually normal, no further follow-up. For those who still had a second abnormal enzyme testing, again, they had those who they thought were at moderate risk, and again, you'll see that 4 out of the about a quarter refused follow-up. The rest continued to have normal exams. And so we had these 4 positives, and that was what was reported in the literature, which is basically what I say here. What we've learned is that we expected the incidence to be about 1 in 100,000. So we expected actually only 5 abnormals, and instead, as you saw, other than the 4 kb deletion, we had another 19. So we actually had about 25 abnormals instead of the expected 5. So again, remember, the only data we really had was from a voluntary registry. They also expected 90% of Krabbe's would be the infantile form, and instead, given the data that we now have, it looks like it was going to be less than 20%, and only 8% had any manifestations of early infantile phenotype. And we have to realize that we're learning this at the expense of extensive follow-up. There was no psychological follow-up done, and in fact, ethicists and people who wanted to try to understand the impact that this was having on families were actually not given permission to actually do any of that research. In 2014, the data should be published later this year. And I got this information from Dr. Kwan of Rochester, New York. As of August 2014, newborn screening had now screened over 2 million dried blood spots. 348 were referred for diagnostic testing. 5 had enzyme activities and mutations consistent with the infantile KD. So in the following 4 years after the first report, only 1 more child had been diagnosed. 4 were now transplanted. 2 had died within months of their transplant. 1 is alive at age 8 but has global delays and is non-ambulatory, but by all accounts is a delightful boy. He has had transplant-associated complications such as autoimmune hemolytic anemia and steroid-related hypertrophic cardiomyopathy. 1 is alive at 5 years of age, severely developmentally delayed. Her course was complicated early on by graft versus host disease. And of course, the other one had died, the one who was not transplanted. 9 are considered high risk, but remain asymptomatic. 36 are considered to be moderate risk, meaning they have not so low Galk activity. All are asymptomatic. And the vast majority of the other 348 were labeled low risk, and none have developed clinical signs, even though all of these kids are being followed. So it's a lot of follow-up for not a lot of great benefit in the end. The treatment of stem cell really comes from Escalar's data of 11 asymptomatic newborns and 14 symptomatic infants. So the 11 asymptomatic were siblings of children who had already been diagnosed with Krabbe, so they could get these kids at birth, the 14 symptomatic. And what they found was all the asymptomatic children successfully engrafted from the stem cell transplant and survived, but all of them developed developmental delays, probably several years slower than they would have had they not been transplanted. But still, all were following, in a sense, the same course as the other children who were not transplanted with Krabbe's. The children who were transplanted by the time they were already symptomatic, again 100% engraft, but 43% survival at a median follow-up of 3.5 years. So it is really critical that you do the transplant prior to symptoms, but the problem is we don't know when symptoms are going to develop. So there was also a question about whether the whole doing of the transplant and the requirement for all of the therapies that you do prior to stem cell transplant might not have exacerbated some of the neurological symptoms, and so they're trying to use a much more reduced intensity myeloablation. No further data have been published by this group. So this was brought up to the Secretary's Advisory Committee. For now known as the Discretionary Advisory Committee. That was the original group that established the Uniform Panel in the United States. And they recommended not to add Krabbe's to the Uniform Panel because of all the problems that I've been enumerating this morning. But despite the data to date, Illinois and other states are preparing to introduce Krabbe as part of newborn screening panels in the near future. So despite the fact that we have this, quote, uniform panel, we're still going to see non-uniformity. And the reason Illinois and Missouri have both introduced it is because of parent advocacy groups going around the metabolic advisory committees in these respective states and going to the state legislature. So what are the ethical issues? One is that it's mandatory, but it's clearly experimental at this stage. And so one could say that that children are being enrolled in research without parental consent. Even if one argued that the protocol is current best practice and the New York group really needs to be commended for what they did, it's not clear, given the results to date, that the benefits of the therapies outweigh the risks, and therefore treatment should not be compelled, and they are not compelling it. For those families who refuse to continue with follow-up, nothing is happening to them in New York. And finally, no data are being collected about the parental experience, which is a real shame because I think we have to acknowledge that following 348 kids on these rigorous protocols will have some harms to these families. In Illinois, where I live, the Bob and Sonia Ivanovsky Foundation has advocated for expanding newborn screening. Their children actually have metachromatic leukodystrophy, which has not been included yet in any newborn screening panels, in part because we don't have great testing and we don't have treatment. But other than that, I mean, we can try stem cells. In 2008, though, we started a pilot study without IRB, without consent, for 6 lysosomal storage disorders. We chose to use a methodology developed by Advanced Liquid Logic to screen for Pompe's, Gaucher's, and Fabry's. We also had planned to test for Niemann-Pick and Krabbe's, but the pilot was stopped because of difficulties with the assay. And then it took us about 6 years and my fighting about how that if we really were going to do this properly, we really should do it as a research study and we should be getting parental consent, whether they wanted it. But eventually I lost. And so in 2014, we piloted again. Again, without IRB, without consent. We decided this time we would use the methodology of tandem mass spec, which is already used for the screening of over 40 conditions. Despite the fact that we failed in getting our acts together with the first set of conditions, the legislation was expanded to include MPS 1 and 2. If you're going to fail, fail big. In early 2015, we began screening at a few centers for some of the 7 lysosomal storage disorders that have been legislated. We're actually only currently, though, screening for 6 because we have not been able to get a contract for genetic testing with New York. We're the only ones who are doing the genetic testing for Krabbe's disorder. So clearly, I'm not convinced that anybody should be screening for Krabbe's disease, and if we are going to be screening, we should acknowledge that it still really needs to be done under a research protocol. The next condition I want to examine then is Fabry's disease, which is also one of the 7 that we'll be doing in Illinois. So this is X-linked, and it's caused by the deficiency of the enzyme alpha-galactosidase A. I practiced saying all these long words last night. Although X-linked, women are not necessarily healthy carriers because they can actually have the full range of symptoms, for those of us who remember the Lyons hypothesis from medical school, although they often appear slightly later and often slightly milder than the male counterparts. Enzyme measurement actually, though, doesn't work for females because there is some residual activity, and so you can't really correlate enzyme activity with disease level. So any enzyme activity, which is going to be the measure that we're going to use in newborn screening, is going to be much more successful, but it's going to miss at least 1/3 of females. The classic phenotype actually doesn't present in infancy. It usually starts to present in childhood with onset of angiokeratomas, acroparesthesias, hypohidrosis, and corneal opacities, usually in the 2nd decade of life. There's also a later onset form, which is progressive, life-threatening complications developing in adulthood, though, can be of one of 3 types. You can have renal, cardiac, or neurologic. The problem, and the reason to argue in favor of screening, although I don't, but the argument in favor of screening is that the average delay from first symptom to diagnosis is 15 years. So parents come in and they say, my kid complains of all these muscle pains. And, you know, I'm a general pediatrician. We get lots of parents complaining about lots of things, and we don't work up every kid. The kid's playing and doing well and things of that sort. And so, you know, first we send them to psych, then maybe they do some other tests, and basically, and so the parents, as you can imagine, this is why the parent advocacy groups are so strong. Because by the time the parents get this child diagnosed, they've been convinced their child's been sick for over a decade. They're angry and distrustful of the healthcare community. And in fact, we don't know how many cases are never diagnosed. How many of these people who end up with end-stage renal disease never actually get a reason? They have some high blood pressure, or they also have diabetes, and we blame it on that without necessarily doing a renal biopsy and actually getting a correct diagnosis. So we really don't know how common this condition is. But what we do know is they don't present in the newborn period. And when you think about why we do newborn screening, it's to prevent morbidity and mortality that we might otherwise miss. There's no argument in favor of doing this as a newborn screen. Now, you could argue, so when should we do it? At age 2, at age 4, at age 6? But we don't do blood tests on children every year. So when are you going to actually capture these kids? And of course, if you don't capture them in the newborn period, you also get into issues of equity, because not everybody has access to a medical home and things of that sort. So there are a lot of reasons, pro and con. I'm not trying to just make an argument why I think my state is misguided. I do acknowledge that there are reasons, and yet just because they're a captive audience doesn't mean that we should test them for everything. So before we developed a therapy, which is enzyme replacement therapy, there was also a Fabry's registry, which included 352 children. The age of onset of symptoms, mostly these neuropathic pain and GI symptoms, in boys was around 6 years, and girls was about 9 years. The most common presenting symptoms, as mentioned, was 60% of the boys presented with neuropathic pain, as well as 40% of the girls. There were GI symptoms, and less commonly in childhood were cardiac involvement. As of the end of 2012, this was the last annual report I could find online, the Genzyme-supported global registry now has 4,482 patients. They have 237 boys and 185 girls under 18 years of age. So what about newborn screening? So there was a study done in Italy in 2006, which only looked at males using a fluorometric approach. They identified 12 with alpha-gal A deficiency. But one of the problems is that it had an 11-to-1 ratio of patients with the later onset. So this isn't even the childhood onset. This is people who aren't going to present till the third or fourth decade of life. If they only looked at those mutations that were known to have disease causing, then they would have had only a 7-to-1 onset of later onset to the classic phenotype. So basically one of the big problems here is that diagnosing children who are going to come on, you're going to, for every one child, you're going to get 7 to 11 individuals who are going to be asymptomatic for 3 to 4 decades. And what do you do with this information? How do you give it to families in a way that's respectful of the family, and then make sure that that information stays with the child as they grow up, so that they have this information that's meaningful when it's really not meaningful for decades. They did another study in Taiwan in 2009. This time they screened for both boys and girls. They did get parental permission. They did cascade screening of at-risk consenting family members. So once you diagnose somebody, since this is X-linked, you can go up and down the family tree. But they got consent for all of that. And here's what they found. Of their 171,977 infants, 963 screened positive and were called back for a second sample. Of these, 94, including 3 females, were recalled to determine their leukocyte alpha-gal A activities. 89 of the 94 came in. 11 males had really, really low, and they all had mutations consistent with having Fabry's disease. The next group had intermediate levels of enzyme, and 64 males and 2 females, and all but 3 of the males had mutations, and then 11 males and 1 female had slightly low activity, but only 1 of them had a mutation. And so what they found was they identified a high frequency of Fabry's disease, of which the majority had later onset phenotype. They missed most females, and the elevated levels didn't distinguish between classic and later onset. So in order to justify newborn screening, you have to say that the benefits of early treatment are so great that you're willing to diagnose people with late onset conditions. And then there's still some of us in pediatric ethics who would question whether we really can be justifying testing kids to figure out what problems some adults might have later on. So what are the pros? You can identify the infantile form. It allows for early initiation of treatment and allows for cascade identification of relatives. The con is that it's identifying mainly adult onset. It's not reliable in females, and so if you're using, well, we have to screen now because otherwise we'll never capture the population again, you're only capturing half the population. The classic phenotype, the symptoms really don't begin in infancy. It's inaccurate to call it infantile. It really should be called classic. And finally, the late onset phenotype, patients may not recall their diagnosis 4 or 5 decades later, and so we still might be in a medical odyssey or have a patient present with end-stage renal disease, and it's never put 2 and 2 together that this might be their Fabry's disease. So what are the pros of screening adults for Fabry's disease? In general, the professional guidelines do not support identifying children for adult onset conditions. If you wait until symptoms, you don't avoid all morbidity, right? So if you start treatment early, even in pre-symptomatic, the goal is to reduce or slow down any symptoms developing. If you screen at any time then after infancy, you're going to miss some individuals. Okay, so we have now 2 enzyme replacement therapies. Actually, here in the US, we only have 1, but we do have therapy. So how effective is this therapy? So here's a study that was done by Anderson et al. Of 289 consenting adults and 22 children with a confirmed diagnosis of Fabry's disease. At recruitment, 211 and 7 children were on enzyme replacement therapy. And here's all the patient demographics. So a very small patient sample. What you'll see is that proportionally more adults are on treatment than our children, and part of this is because, again, we don't actually, if we wait until they become symptomatic, it's a problem, but you also don't want to start treatment if these kids aren't going to have symptoms for 30 or 40 years. Here is the efficacy results, and one of the things that you can see is that for the left ventricular hypertrophy, not effective in pediatrics. For the proteinuria, no clinically significant difference. For the proteinuria, no clinically significant difference. Part of this may be small numbers. There is some suggestion it might have some bit of help with the kidney, but not at all help with the left ventricular mass. So the study proves provides some further evidence for the limited efficacy of enzyme replacement therapy on cardiac and renal parameters in adults, but even more so that in children the numbers are very small, but really no benefit at this time. And again, part of this, though, is that the major morbidity is not going to happen for decades. And so the question is, you put somebody on enzyme replacement therapy for decades when you're not sure that it's going to be effective, number one, but number two, for all of the morbidity that can happen from being on therapy for years and years and years. And here was the end of that article. We recognize the difficulties in mounting large randomized placebo-controlled trials powered on clinical outcomes, but have shown that observational data from a cohort study can be used to provide estimates of treatment effectiveness, and then go on to acknowledge that really has some possible benefit in adults, not much in kids. Where are we today? Despite the fact that we don't have a very good therapy, and despite the fact that we really don't need to be screening until they're older, Missouri and Illinois are screening. Missouri is using digital microfluidics. Missouri presented their first 6 months of data that they diagnosed 15 all boys with Fabry's disease for a showing a relatively high frequency. They have no outcome data to date in the literature. Illinois, we're using a tandem mass spec, and we've just started that in the last few months. Okay, so clearly I'm voting against Krabbe's, clearly I'm voting against Fabry's. What about Pompe's disease? And this becomes important because this one was actually just recently approved by the Secretary Advisories Committee. So, variable but progressive intralysosomal glycogen storage disease in skeletal, hard, and smooth muscle. But just like the other two, our biggest problem is that genotype doesn't equal phenotype. This, though, has a better, in a sense, presentation in that the early onset to late onset ratio is only 1 to 2, so we're not going to be diagnosing lots of people, many of whom won't become symptomatic for decades. The infantile form, the natural history is that untreated children die at about 1 year of age due to cardiorespiratory failure. They often have progressive left ventricular hypertrophy and hypotonia. Cardiomyopathy actually may be present at birth, and they have feeding problems. The non-classic or the older presentation can be anywhere from childhood, juvenile, or adult onset, and they often present with progressive muscle weakness as well as cardiac involvement, usually arrhythmias. So here was one of the early newborn screening programs in Taiwan, which was actually, again, done as a research protocol with IRB approval and informed consent. And what they did was they screened half the population. This is, for Ben, it's going to look very similar to the CF. They screened half the population. They didn't screen the other half. And of the half not screened, 3 go on to get diagnosed between 3 to 6 months of age. For the 132,000 who are screened, we end up with 4 diagnosed with Pompe disease, 3 with the infantile form, 1 later onset. So pretty similar results. The screening measures GAA activity using, again, either fluorometry or the tandem mass spec. And then you also have to assess for something called CRIM, which is cross-reactive immunologic material, which basically, if you have any amount of enzyme activity less, you're going to be CRIM positive. If you have no enzyme activity, you're going to be CRIM negative. And the problem is the CRIM negatives, which are often the most severe, so often the infantile, do not respond to the enzyme replacement therapy. So more data from Taiwan between 2005 2009. They did newborn screening for Pompe's. They then had 344,000 newborns, 13 of whom were found to have later onset Pompe's, 2 cases of late onset for each case of infantile. So again, this problem of diagnosing people for adult onset conditions. During a follow-up period of 4 years, 4 of these patients with, quote, the later onset, though, do develop symptoms, 1 at 1.5, 1 at 14, 34, and 36 months, respectively. So later onset, again, we don't know whether that means months or whether that means years or decades. Newborn screening was found to facilitate then the detection of both infantile and later onset. And so then what? More data from Taiwan. We get 402,000 kids screened, 6 infants with the infantile onset, and now we have the development of enzyme replacement therapy, so we begin to use that. They had 20 cases suspected late onset Pompe's, and they're not going to treat these kids at first. One of the big problems in Asia is that there's a lot of cases of pseudodeficiency, which makes it really hard to distinguish then infantile onset versus late onset versus the pseudodeficiency. So a lot of follow-up for these families, a lot of distress. They are getting a little bit better with some genotypes, knowing that they correlate with pseudodeficiency, meaning that these kids are actually normal. So with the infantile onset, we have hypotonia, high CK, and high left ventricular mass index. All 6 CRIM positives were begun on enzyme replacement, and all appear to be doing quite well. So what have we learned? The initial recall rate was too high, and so they had to change some of their measurements. They then developed a second-tier test, which reduces false positives and recall rate. It's been validated in Japan as well. The con is that you can't multiplex it. You can't do it with a tandem mass spec on one sample because they all employ the same substrate. Long-term follow-up, neurological symptoms were not known to occur. When we first had the Pompe's disease, we had very specific about the skeletal and the cardiac. We didn't actually know about any of the neurological symptoms because most of these children never survived. Now, as these children are surviving on enzyme replacement therapy, we're realizing it doesn't cross the blood-brain barrier, and we're dealing with neurological symptoms that develop in these kids: cochlear dysfunction, delayed myelination, and bulbar involvement. And that despite the fact that enzyme replacement therapy is helpful, they still do develop. So again, it's more of a slowing down of the disorder rather than curative. So what are the pros? Early treatment of early onset clearly improves prognosis. The early diagnosis, so of later onset, often does present in childhood, and so frequent follow-up here can be justified in contrast to Krabbe's and Fabry's disease. The cons is that we have this high false positive rate, and the revised diagnostic methodology is quite labor intensive. And why is that important? And the reason it's important is because we have to think about our medical resources as a scarce resource. And does it make a lot of sense to be using all of these resources for diagnosing such a rare condition when we have, thousands of kids who aren't getting immunized appropriately? Finally, we're identifying still a 2-to-1 ratio of adult conditions rather than pediatrics. So is newborn screening ready for prime time? Clearly, screening tests exist, at least for Krabbe's and Pompe's. For Fabry's, we have a good screening test for boys, not for girls. Can the diagnostic test accurately distinguish infantile from late? Not really. A little bit better with Pompe's if combined with clinical exams and other labs, but still we're going to be diagnosing a lot of adult onset. Is the natural history understood? The answer is yes, and learning. This has been an incredibly important research project. Unfortunately, it's being done without parental permission or with IRB oversight. Is there an efficacious treatment? For Krabbe's, it's not clear whether I would call stem cell really efficacious. For Fabry's, there's enzyme replacement, but not clear that it works in kids. For Pompe's, the enzyme replacement is known to work, but only if you're CRIM positive. Is there an agreed-upon policy on whom to treat? For Krabbe's, the answer is no. For Fabry's, we say early treatment once symptoms develop. Pompe's, it seems that we have a greater agreement on whom we need to be treating. So is it ready for inclusion? I would say Krabbe's definitely not. Fabry's, no. But if we are going to screen, should we only be screening boys? And Pompe's, I would say maybe. We need to reduce the number of false positives and the number of late onsets being diagnosed. So clearly, I am not in sync with my own state, probably not in sync with many of the state labs. But again, it turns out to be a fight amongst the parent advocacy groups than it is about the medical community. So let me just conclude by what are the ethical issues that I see in the newborn screening for lysosomal storage. This lack of parental consent for pilot programs of unknown sensitivity, specificity, particularly when we don't have an effective treatment. We're identifying variants for which the natural history is not well known or understood. We're identifying variants that do not present until adulthood, and we really talk about newborn screening as preventing early onset morbidity and mortality. And so the problem here then is by joining them, we're going to possibly get some families refusing because they're conflating, you're testing my kid for Krabbe's versus you're testing my kid for PKU. We want 100% uptake of PKU. We're not as adamant about Krabbe's, Fabry's, or Pompe's. We're going to identify conditions for which treatments don't exist, they're experimental or are not highly efficacious, and then what are we going to do with it? We're finding a lot of problems with even getting the genetic testing being paid for by insurance companies in Illinois. Are they going to pay for treatments that are not known to be effective? We have carrier identification and the right to privacy regarding genetic information. And as I've mentioned, only Pompe has met the standards for inclusion in the newborn screening panel. And since we now have a national organization who's responsible for determining when a condition meets the criteria for population health screening, the fact that some states are going above and beyond might not actually more is not always better. We'll leave it at that. And so on that note, I will end. Thank you very much.
Eleni left plenty of time for questions. I want to point out we have microphones in either aisle, and the reason we do that for these grand rounds is to really facilitate conversation so people can be aware of who else wants to speak. So I'd like to invite people to come to the microphones on either side if they have questions. And I think, Bruder, you got the first question.
There we go.
There we go.
Laney, thank you very much. I'll get away for being here. You're always very provocative. I have just a comment and a couple of questions. One is that Bob Guthrie was on my faculty when I was chair at Buffalo. And he had a child with developmental disabilities that really inspired him for the original. And my understanding was there was never any true clinical trial. It was done with Bob Warner at Buffalo and a relatively small group of kids without any IRB. So it was kind of the whole initiation of the newborn screening. The Guthrie Spot was kind of a passionate individual that got it started. When he passed away, he was working with, late in his life, with people in Japan. He had a screening test he thought was very effective for neuroblastoma, but it could only be done at 6 months, and they were never able to figure out how to actually integrate that into any health system. So your comment about you have a captured audience is really a kind of a key to being able to have universal screening. A question I have in terms of different from the parental anxiety is when we use an economic discussion of the value, having a newborn screen greatly facilitates doing additional tests on the many kids who may have symptoms associated with the, that might be associated with the condition, but if you have newborn screening that says they don't have it, in other words, the long-term cost of evaluating illness has been greatly changed. We know whether someone has sickle cell trait or not. We know someone's been tested for CF or not. So there are many children who have symptoms down the road that are not put through, and that they then have false positives in the future themselves. So I just wonder, when you do an economic model, do you really look at the continuum of healthcare? Is it only for that short period of the test?
So I'm going to answer your question first, although I like the history part better, to be honest. So the fact is that when a 3-week-old comes into the emergency room failing to thrive, I don't care how many times you tell me that you did the newborn screen for CF, I'm going to repeat a test for CF. So to that extent, and there are misses in newborn screening. No test is 100% perfect, particularly in minority children. And so when the 3-week-old minority child comes into the emergency room, the hope is that we're also going to think about doing CF newborn screening and not think first medical neglect, right? And in fact, California is the leader in this, in trying to create a panel that represents their population. They've gotten to the point now that they're actually doing whole genome sequencing, and they're finding lots and lots of variants in the CF mutation. The problem is many of those are leading to CRMS, which is CF-related metabolic syndrome, which doesn't necessarily need treatment, but we're not really sure what to do with these kids, so we're following them for life. So despite the fact that we have newborn screening and it's supposed to give us a yes or no answer, the answer is sometimes it's giving us a maybe answer, and despite the fact that it's giving a yes or no, there are false negatives, so we're still following up. Every kid who comes in failed to thrive gets another test for cystic fibrosis at least once. But that was part of the economics. So does it help economically? Yes, except that there are false positives, so that has cost, and it has false negatives, and it has this whole middle, what do we do with these kids with this middle condition? More interesting was hearing the stories about Bob Guthrie. I love the history part of it, and I had the privilege of actually giving a newborn screening lecture in Buffalo, where I got to talk about from PKU to Krabbe, because they're both starting in a sense in New York. The interesting thing is he did have a child with intellectual disability. It turns out after he develops the PKU test, And it turns out he has a niece with PKU who actually never got screened and ended up having significant intellectual disabilities. But he was part of the advocacy group, so he did view himself, as I said, he viewed himself as a used car salesman, both very supportive with the parent advocacy groups and trying to get it along. He's a chemist. He wasn't actually a clinician, and so didn't fully appreciate why there was so much pushback from the medical community. You know, he actually gets, because the advocacy groups are so adamantly wanting to get PKU started, they don't wait for even having a proper article published. Instead, he and his researcher, Susa Addy or something, I think that's what her name was, end up writing a letter to the editor in Peds, and after that it's then publicized at a March of Dimes meeting and made a big splash, which also angered the medical community, feeling that they didn't have adequate opportunity to sort of look at his data and see whether this really made sense to be doing or not. He doesn't actually publish that for another 2 years, during which time he's already, you know, gotten many, many states to start universal newborn screening. So sorry, I love the history. I just had to comment on it. Ben.
Well, Lainey, first, thank you for a terrific talk and discussion. I want to get your thoughts about the issue of conducting research in newborn screening and how to think about that. And I guess there's two points I want you to comment on. One is your view about when it's appropriate to call something research versus a pilot study and the implications of that. In particular, you made a number of comments about informed consent. And I want to at least suggest to you that there are different ways of interpreting informed consent, and both from a regulatory perspective and from an ethical perspective, in both cases, it can be a very wide spectrum. So informed consent could be a very long form that a person stands in front of somebody and goes over with them for an hour, or it could be some information or brochure and somebody can opt out if they don't want something. Can you elaborate further on approaches to consent and thinking of this as research?
Yeah, so I want to start with the consent, because I think one of the dangers of adding the lysosomal storage diseases is that if a parent has heard that, for whatever reason, doesn't want their child tested for Krabbe's, the biggest risk in my mind is that they therefore refuse newborn screening. And so by lumping conditions that have early onset morbidity and mortality with conditions that we're, quote, piloting, I think is harmful. I think that we risk, when parents say no thank you to one, what they don't understand is how, in a sense, at this point, we know how effective some of the newborn screening that's been standard for 30 years really is. And so I think that what we need to at least acknowledge with newborn screening is this is the newborn screening that we've been doing for 30 years. What we know is that if you get a positive test, we're going to call you back, and we have a treatment that can prevent morbidity or mortality, right? I don't think you need to go into much more about sickle cell and hypothyroidism and galactosemia and things of that sort. We're now adding some other conditions where we're testing it. We're not fully sure how to diagnose it, and if you get diagnosed, we're not even sure if we have treatments. What we do know is we're not abandoning you. We're going to be there with you along this journey. But it's a journey, and whether you call it a pilot study or research, it's a journey, and the families have the right to know up front that there's a lot we don't understand, that we're asking them to participate. Paul Ramsey from Princeton, who died in 1988, would have told us that you have to be co-journeyman in this process. He was actually one of my advisors in getting me to become a medical ethicist. But he talked about what you need is that the participant, whether you call it a research subject or a participant, needs to be a part of the journey. And I think we've lost that by just including it into a mandatory newborn screening program. So that's in response to your consent. Okay, I'll let you ask the second part.
Just to follow up really quickly on that, 'cause that was terrific, but I want to clarify what you describe about the journey. It seems to make a lot of sense when somebody's been diagnosed. And the question is, do you have to have that conversation explicitly with every single parent in the state?
Yes, because not every parent wants to be part of that journey. And they have the right not to be if we really don't know what we're doing with it.
For those that don't want to do that, can there be, I can imagine there will be a small number who will actually probably form their own support group and a variety of things like that. No, I mean very seriously. And so as long as they have the option of opting out, I wonder whether there can still be a presumption of going forward, except for those individuals who specifically prefer not to, rather than assuming nobody will want to unless they say yes.
So nowhere in my consent did you notice a 10-page form. I gave you a 4 or 5 sentence description, and I think that's the key, is that we keep it that way. But I wanted opt-in for one very specific reason. Opt-out means I don't have to talk about it, because if you don't say no, then I can keep going. And what we do know about newborn screening that's mandatory and universal is that because it's mandatory and universal, we don't talk about it. Parents, we actually did a study, it's one of my favorite studies, where a medical student, as moms were leaving the well baby nursery, we asked them why their child had a Band-Aid on the bottom of their foot. And the answer was that they got the newborn screen, is the correct answer. And about 20% knew that. Some of them thought we had tested for jaundice, some had thought we had tested for drugs. One mom was convinced we had taken blood to clone her child. Okay, of the 80% who knew we had done a newborn spot, less than 10% could name any condition we were testing. So we're missing, it's a failed opportunity for a little bit of education. And why is education important? Because when they get the positive screen, then they know what to do next. If they don't, they might not do anything with it. So it's actually dangerous, as well as the fact that it's disrespectful by not assuming that they can understand. They don't need to understand a 10-page consent form. I can't even pronounce half the words. What they have to understand is when their child is at high risk and needs follow-up.
I wanted to make one comment. I'm not an ethicist, I'm a geneticist. And, I think one of the themes of your talk could be that we need more research on correlations between genotype and phenotype. And I mean, this is, for every single one of those disorders, you had a sentence saying genotype does not equal phenotype, and I couldn't emphasize that that's true more. And that's true for almost all genetic conditions, which were originally identified, the most severe cases, and then as we go along, we see that actually one example I wanted to bring up, that which is well known is BRCA 1 and 2, which of course the incidence of developing breast cancer is coming down in people who are identified as we find more and more people genetically rather than phenotypically. And on the breast cancer related topic, I just wanted to say, one of the things you talked about was, newborn screening is a captive audience and it's a good time to catch everybody. But, we certainly screen the population at times beyond when they're born, right? I mean, we do mammograms, and although there are also controversies associated with that, PSAs and things. And there have been proposals to introduce sort of more genetic type of population screens at later ages. And I think that's something that, maybe not for these disorders, but for some of these disorders in general, where we are getting a lot of adult onset, screening in kids for things that are mostly adult onset, which we don't really want to do. We can consider, although recognizing we'll miss some of them because of follow-up and things like that, doing some of these kinds of screenings at a later age.
Totally support it, but I would also support it with consent, right? I'm not going to screen women or men for BRCA without getting their consent. So it is this interesting thing that we feel that we can do pediatrics without consent. So one of the answers, well, the kids can't consent, but we could get surrogate consent. So what was the original justification? A lot of the justification was, parents wouldn't understand, and so they would make a bad decision. Again, I think it's just disrespectful. I think if you give them a 2-minute explanation, and it doesn't even have to be a full 2 minutes, that people can understand what you're looking for are rare conditions that if my child has it, you can prevent morbidity or mortality. I'm on board, right? But we don't even respect them that much to give them that information. And so I actually think that realizing that that the more we're learning about genetics, that we might want to have more population screening at different ages, and whether it's, again, at 18 or whether it's at 25 or whether it's at the discretion of physicians, but that we should be developing guidelines and thinking about some of these conditions, because yes, we're realizing that that BRCA is less penetrant, but we may also start to realize how many people that we might prevent end-stage renal disease if we were picking them up having Fabry and other conditions of that sort. So I would totally support what you're suggesting, totally.
Great talk, lady. So I wanted to combine your comment about the journey and being on the journey with the parents with Bruder and your discussion about the history of newborn screening. And also your comments about the advocacy groups and the policy component of how newborn screening policies are influenced both on the state level and the national level and the discrepancies between them. Because I think, thinking back on the history of newborn screening, part of the problem is that parents of these children with these incredibly rare diseases did not feel like the medical community was on the journey with them, did not feel like society was on the journey with them. They felt abandoned. They felt like most of the medical profession thought their children were better off dead. And in some cases, that may have been viewed as true by some families because there really was no treatment and no social supports for them. And I think it may still be true today to some degree, in that newborn screening as a policy, particularly with Guthrie spots, was sort of trying to prevent the disability from happening in the first place, which is of course something we all can get on board with, but wasn't really about continuing the journey with the patients who still have the complications, developmental delays, other problems like some of the patients you talked about in the examples from the different tests. And so I guess I wondered if you could comment on what you thought the medical community and the ethics community could think about the issues involved with these families feeling abandoned and feeling like newborn screening is the only action they can take to help their children, and all your alternative approaches that as a profession, as a society, we can do to support families who are affected by some of these rare diseases with very severe consequences that might be different than applying newborn screening broadly to the whole population.
Yeah, so thank you. That's a really great comment. So there are a couple of things. One is, the parent advocacy groups, though, there's also been a little bit of, I just want to, and then I'll get to your question, I promise. There has been a little bit of a lashback. So the parent advocacy groups who were the most adamant about getting newborn screening and expanding it are also the groups who are trying to destroy the blood spots that sit in all of our state labs because you didn't get consent and we didn't know about it, and you're doing research on my child's blood spot without my permission, and have actually been successful in 2 states. And now actually with the new NPRM, the way we're going to change research ethics and human subjects protection, we're actually now going to need consent for every single blood spot, even if used anonymized and de-identified, if we can't do it anonymized and things of that sort. So the families have been really powerful, both stopping as well as promoting. So I just want to say that parents aren't all just gung-ho, let's keep going. We have to acknowledge that as well. And so that's part of my answer to you as well, is that right now the parents who are responding to with newborn screening are those who do have children who have been affected and who are feeling this is the only way to be heard and to have the doctors on the journey. And yet there's a larger community who are also feeling you've been in a sense misusing and misappropriating my samples and things of that sort. So I think there's the two-edged sword. But your point is really well taken. It turns out that most medicine doesn't cure. We sort of ameliorate and make things better, but symptoms are still going to come through, and that's something that we need to learn. Internists have always known that. Pediatricians, when I went to medical school and residency, we talked about acute diseases, and pediatrics is becoming very much a chronic disease. So you're right. Healthcare providers need to realize that we need to be part of that journey, and we need to be part of that journey from before diagnosis through the entire child's life. So I think that's a really important point. Thank you.
We are actually at the end of our hour, so let me thank Lainey again for Grand Rounds, and we do have she is giving a seminar this afternoon at 3 o'clock over in the old Whale 3, whatever it's called now, on sickle cell carrier testing for NCAA athletes.
Thank you.
Go ahead.